Okay, so to start off with some definitions. So asthma, the two sort of key buzzwords that you want to remember is that it's episodic and reversible airway narrowing in response to certain stimuli. Reversible being a really key one as well, particularly with regards to how we diagnose asthma with the reversibility test that's performed as well, but we'll go on to talk about that a bit later. There's some key symptoms of asthma, which I'm sure you're all aware of: wheeze, shortness of breath, chest tightness, and a non-productive cough. You might hear the term diurnal variability as well. Often the cough, basically that just means that the cough and some of the symptoms can present worse at night. So there's a variation in the symptoms throughout the day, with nighttime being the worst time for the symptoms. And also just to keep in mind that asthma is obviously a chronic condition, but it can present more chronically, rumbling along in the background, as well as with more acute exacerbations or attacks on top. Okay, so a little bit about epidemiology of asthma. So it's the most common respiratory condition in children, affects millions of children in the UK. It's also a very common paediatric emergency to be aware of. If you ever work in an emergency department, you will see lots of children coming in with acute asthma and wheezes, particularly around Christmas time. So moving on to our first question. So a 12-year-old boy is brought into, with 1 year history of a wheeze, dry cough, which is worse at night, is brought into GP. After taking a full history, you learn that he also suffers from eczema, as do his mother and sister. His father also suffers from asthma and hay fever. The only positive finding on examination is a widespread wheeze heard throughout the chest. Which of the following immunoglobulins or antibodies is most likely to be raised on investigation of this patient? So I think there's going to be a poll that you can put your answer in now. I'll give you a few moments just to think about your answer. Okay, right, so the overwhelming answer is C. Let's move on to the answer. Correct. Okay, so yes, most of you are correct. IgE is the answer. Just a little bit of a sort of pre-word about this question. I was trying to kind of get at the fact that IgE will be raised in particularly allergic asthma. I'm not saying that particularly measuring IgE levels would be like a key investigation that you would do in childhood asthma. It's more just to highlight that IgE might be raised. So I'll talk through very briefly the different options. So IgA is a pentamer usually, and it's like a key secretory antibody. So you find it in secretions like milk, saliva, and mucus. Which means that you find it in areas where secretions are more common, like the gut and respiratory tract. IgD exists generally as a monomer. It's involved in the development and maturation of B cells. IgG is generally found as a monomer as well. An important thing to know about IgG is that it's the only antibody that can cross the placenta. So it's really important with regards to conferring immunity to the fetus. And IgM exists as both a pentamer and a monomer. The pentamer form is really important in the early stages of B cell mediated immunity. And IgG, which is the answer, is important in allergy. It basically helps to sort of attract eosinophils and activate eosinophils and mast cells which trigger histamine release. Okay, so it would be seen to be raised in lots of allergic processes like allergic asthma. Okay, so moving on. A little bit about the pathophysiology of asthma. So, in a nutshell, asthma is caused by a combination of two factors: inflammation of the mucosa and hyperreactive narrowing of the mucosa. So I've just included a little bit, I know it's quite wordy, but hopefully this slide will be helpful when it comes to revision. Just giving you a bit of the physiology going on in the background. So the inflammation of the mucosa is mediated by T helper cells, which basically attract eosinophils and then attract things like leukotrienes, prostaglandins, and histamine. And then with regards to the hyperreactivity of airways, so essentially that hyperreactivity causes inappropriate bronchoconstriction and reversible airway narrowing. And then just a little reminder about bronchoconstriction and bronchodilation. Bronchoconstriction is a parasympathetic action caused by release of acetylcholine onto muscarinic receptors, whereas bronchodilation is a sympathetic action caused by a release of adrenaline onto beta adrenoreceptors. Okay, and then a bit about the broad types of childhood asthma. So we've already talked a bit about the third type, atopic or allergic asthma. So this type of asthma is going to be the kind of asthma that you would see persisting more into adulthood. It's often associated with other atopic conditions like eczema and hay fever. And then you've got two other types of asthma that are more commonly seen in younger children, but then kind of resolve as you get towards the ages of 4 or 5. One of which is transient early wheezes. These are children that will develop regular viral upper respiratory tract infections and with that develop a wheeze. But generally they kind of grow out of this, and by the ages of 3 or 4 that doesn't happen anymore. And then similarly to that, but without the sort of viral element, you get non-atopic wheezes. Again, children that kind of develop this wheeze periodically but grow out of it in later life. And that 1 and 2 can kind of be what makes diagnosing asthma in children a bit harder, because it's so hard to tell whether this is actually going to continue to persist into adulthood, or whether it's something that's just going to kind of resolve by the ages of like 3 or 4 years old. Okay, so moving on to question 2. A 15-year-old boy presents to GP with a 4-month history of coughing at night, which is waking him up, as well as a wheeze. After taking a full history and examination, you suspect asthma and decide to perform an investigation to confirm your diagnosis. Which of the following would you choose as your first line investigation? Fractional exhaled nitric oxide, trial salbutamol and return for review in 2 weeks, keep a peak flow diary over the next 2 weeks and return for review, direct bronchial challenge test with histamine or methacholine, or spirometry and a bronchodilator reversibility test. So I'll give you a few moments to put your answer in. Okay, and it's a bit more split this one, but generally people seem to be saying E. Few people going for trial salbutamol, few people going for peak flow diary. Okay, so we'll move on to the answer. It was E, which is what the majority of you went for. Basically in a nutshell, first line for confirming a diagnosis of asthma is always going to be spirometry with a bronchodilator reversibility test. Those would be your first options. I'll go through in more detail on the next few slides some of the other things like keeping a peak flow diary, direct bronchial challenge tests, fractional exhaled nitric oxide, but just a little bit about option B and why that's not the correct answer. So in this patient, he's a 15-year-old boy, which is important. He's got past that age where it's hard to tell whether this is a sort of transient viral wheeze or whether it's a true allergic asthma. He's got barn door asthma symptoms. So just trialing salbutamol in him isn't going to help. It's not going to give you a diagnosis. And also, if you do suspect asthma and you do want to treat it, it's not even the correct treatment. We'll go into that in a bit more detail later on. But that's why you might see sometimes in GP this happen, particularly with younger children. Sometimes children will come into A&E and have that kind of viral wheeze and they'll get sent home with salbutamol. But this is quite a different scenario. This is a 15-year-old boy with really clear asthma symptoms. So you're going to want to try and confirm that diagnosis. Okay, so a little bit about the different tests that we mentioned. So spirometry is a form of pulmonary function test, as I'm sure many of you are aware. It involves looking at both the FVC, the forced vital capacity, which is getting the patient to basically force as much air out of their lungs as possible, and the FEV1, which is how much they can force out within the space of 1 second. So it kind of looks at how good they are at, how quick they are at emptying their lungs. And then you look at the FEV1 to FVC ratio to see whether there's an obstructive pattern going on. Obviously, asthma is an obstructive airway problem. So if that ratio is less than 70, that implies that they're struggling to empty their airways as quickly as they could be. So spirometry is a key part of investigating asthma, and it goes hand in hand with the BDR, the reversibility test. So essentially, if you do spirometry and you see an obstructive pattern, the next step is to confirm that it's reversible. You do that by giving a SABA like salbutamol and seeing whether there's any improvement. If there is improvement in the FEV1 of more than 12%, that indicates reversibility. Other tests that are used as well is fraction of exhaled nitric oxide. So that's generally a marker of eosinophilic inflammation. Obviously, if you've got asthma and you're going to have a high level of eosinophilic action, then that number would be higher. Another thing that's used is peak expiratory flow variability. So peak expiratory flow rate would be measured using a meter. You give the patient a meter and a diary and ask them to take measurements over the course of the day for a period of 2 to 4 weeks. Generally in asthmatic patients, you see that variability, particularly that diurnal variability in their peak flow, and a variability of more than 20% can be used to help diagnose asthma. So this next slide is a bit busy, but it's just to kind of help you see what the general pathways are for how you diagnose asthma. So like I said, the first test, you suspect asthma, you would do spirometry. If you see that obstructive pattern on spirometry, the next thing that you would do, going towards the right, is the BDR test. If that is also positive and you see reversibility, then you've got your diagnosis. If it is negative, then your next step would be to look at fraction of expired nitric oxide. If that's raised and also so suggestive of asthma, then you can use peak flow readings as well. If that's suggestive, if there's variability, then you can suspect asthma and commence a trial of treatment. If the nitric oxide level is not raised, then you might want to consider referring to a respiratory specialist because they've got an obstructive pattern that you're not able to kind of pin down exactly what's going on there. If they don't have obstruction on their spirometry, then again you go to fraction of exhaled nitric oxide and you'd use that in combination with peak flow readings. If one or the other is positive, and suggestive of asthma, you can trial commencing treatment. If they're both positive, you can diagnose asthma, and if they're both negative, then again, you might want to go back to the drawing board and think about another diagnosis or referring to a specialist. Okay, on to the next question. A 4-year-old girl presents to GP with a shortness of breath after running in the garden with her siblings. After taking a full history, you note that she's otherwise generally well and is able to talk as normal. She has a history of eczema and a persistent wheeze for the past 3 months, for which she was given salbutamol by her GP to good effect. She is currently awaiting spirometry for a suspected diagnosis of asthma. On examination, you find her to be warm and well perfused. You see no evidence of accessory muscles for breathing, only a mild nasal flare. On auscultation of the chest, you hear a widespread wheeze, but no crepitations, and no other significant examination findings. Her OBS are as follows: oxygen sats 95% on room air, heart rate 138, BP is 110/70, rest rate is 35, and temp is 36.8. So which of the following is the most likely diagnosis? Is it A, bronchiolitis, B, moderate asthma, C, acute severe asthma, D, acute life-threatening asthma, or E, a viral-induced wheeze? So I'll give you a few moments to think about your answer. Okay, so B seems to be the general consensus. All right, let's move on to the answer. Correct, most of you got it spot on. Moderate asthma is the answer. It's pretty suggestive in this question that asthma is the thing that we're thinking of. Even says that she's being investigated for a suspected diagnosis of asthma. I'll go into more detail over the next few slides what the definitions are for moderate, acute severe, and acute life-threatening asthma. But I'll just go into a bit of brief detail now about answers A and E, bronchiolitis versus a viral-induced wheeze. So bronchiolitis is a viral lower respiratory tract infection that's mostly, I think about 80% of it is caused by the RSV virus. It generally affects children under the age of 2, most commonly children under the age of 1. And it's something that you will definitely see coming in around Christmas time, particularly into A&E. The main symptoms of it are babies which are coryzal, have increased working breathing, and have developed a wheeze. And the treatment for it is generally supportive. Things like salbutamol don't have any benefit in bronchiolitis. So obviously that wouldn't be the case in this question. She's 4 years old, she's too old for bronchiolitis. She doesn't have any coryzal symptoms. And then E, a viral induced wheeze. I used to find it really hard to get my head around the difference between bronchiolitis and a viral induced wheeze, particularly in that kind of transitional age of like 2-ish. Where they could get both. Generally, a viral-induced wheeze will affect children under the age of 3. It's again a viral infection, but more commonly a upper respiratory tract infection, and it does have it does respond to bronchodilators. So there is a benefit of using salbutamol in these children, and quite often these children might get sent home with salbutamol to try at home to kind of help ease the symptoms over the next few weeks. However, differing to asthma is the fact that you wouldn't use systemic corticosteroids in children with viral-induced wheeze. So there's no benefit of giving them prednisolone, whereas you would in asthma. So just a little bit about the different ways of how we sort of categorize acute asthma presentations. The importance of this is obviously that it affects how you would manage the patient and helps you kind of categorize those life-threatening and severe patients that you really want to escalate and treat seriously. So moderate asthma exacerbations, you generally see children that are able to speak in full sentences if they're able to talk yet. Their SATs aren't particularly affected, they're over 92%. Their peak flow is over 50% of predicted. They're not particularly tachycardic or tachypneic. Moving on to severe, these are children who might be unable to complete sentences without pausing for a breath. And particularly one thing that's quite helpful thinking about younger children that can't talk yet, they might seem too breathless to feed. That's a good kind of like symptom to look out for in these children. Oxygen saturations are affected, they're less than 92%. Peak flow is again more affected, and these children might be tachypneic and tachycardic as well. And then life-threatening essentially is all the features of severe asthma plus one of these other features. So a really severely affected peak flow of less than 30% of predicted, silent chest, cyanosis, poor respiratory effort, hypertension, exhaustion, or confusion. So moving on to the next question, a bit more about how you'd investigate somebody presenting with asthma. So an 8-year-old boy with a history of asthma presents to A&E with acute shortness of breath. After taking a full history, you learn that this started whilst playing football in the park. The boy has no other symptoms of note. On examination, you see that the boy is sat forward using accessory muscles to breathe. He's unable to complete full sentences without taking a breath. You hear a widespread wheeze on auscultation of the chest, but no crepitations. Observations are as follows: heart rate 135, BP 118/80, temp 36.7, oxygen sats 91% on room air. You suspect a diagnosis of acute severe asthma exacerbation. Which of the following investigations would be the most appropriate to conduct? Is it A, a chest X-ray, B, an ABG, C, a full septic screen, D, immunoglobulins, or E, peak flow rate and continuous oxygen monitoring? Again, I'll give you a few moments just to complete the poll. Okay, let's see what the results are. Ooh, so quite split this one. Is it an ABG or is it peak flow with oxygen sat monitoring? Okay, so the answer is E, peak flow rate with oxygen saturation monitoring. I'll go through each answer and explain why. So starting with A, chest X-ray. The thing I was trying to get at here is that there is no, when you're suspecting asthma, particularly in children, there's no real benefit of doing a chest X-ray. It's not particularly beneficial. It's not going to give you any extra information. And particularly in children where you're trying to avoid any unnecessary irradiation, the chest X-ray definitely wouldn't be appropriate. There's nothing in this history that's making you think maybe there's some kind of infective process going on that you might want to investigate further. Maybe if you're suspecting a pneumothorax, but that doesn't seem likely in this child. So chest X-ray is not the correct answer here. B, arterial blood gas. I can see why a lot of you went for this one, and definitely in adults that might be, they've done a lot more, particularly in A&E. There might be a scope for doing a capillary blood gas in this child if he had really deteriorated and continued to deteriorate, and you're wanting to look at things like lactate. Generally, you can use oxygen saturations as a way of measuring the oxygen sats in the children. You don't need to do an ABG to measure the oxygen levels, and generally ABGs just, you don't see them performed in children very often at all because they just seem to be quite distressing. again, if something is if you do need to do a blood gas, then it will generally be a capillary blood gas that can be done just through finger prick. Still quite distressing to some children, but much less distressing than an ABG. So that's why ABG in this case would not be the right answer. It's going to be too distressing. It wouldn't give you that much additional information. If you really wanted to do it, you'd do a capillary blood gas. C, full septic screen. Obviously, none of you went for that. That's not indicated. There's no indication that this child is septic. If they had some kind of infective symptoms, a productive cough, coronasal symptoms, pyrexia, then maybe, but that's not the case. Immunoglobulins, as I said earlier, you don't necessarily check for things like IgE in asthmatic patients, even in sort of primary care chronic roles. Definitely that's not something that you would do in an acute setting. So the answer was E, peak expiratory flow rate and continuous oxygen saturation monitoring. Particularly continuous oxygen saturation monitoring is important. Obviously, understand sometimes it might be hard to do a peak flow rate in an acute setting with somebody that's acutely unwell. You might not necessarily stop and get them to do a peak flow rate, but it is supposed to be part of how you would investigate asthma and help diagnose what category you put it in. But I would say the key part here is continuous oxygen saturation monitoring, because it tells you how severe their condition is, and it helps you monitor as you're giving them the treatment how they're progressing. Okay, so question 5, moving on to it straight away, sticking with our 8-year-old boy. Is there a way to move that poll out the way of the question? There we go. So this 8-year-old boy is admitted for treatment of his severe asthma attack and commenced on nebulized salbutamol and ipratropium, which were given back to back. Which of the following treatments should also be commenced early in the management of this patient? Is it A, nothing, that's the full sufficient management, B, oral prednisolone, C, IV magnesium sulfate, D, aminophylline, or E, IV hydrocortisone? And I'll give you a few minutes to pop your answer into the poll. Okay, so most of you went for option B, with a few people going for A or E. Okay, so let's see what the answer is. The answer is B, oral prednisolone. So I kind of gave this one away a little bit earlier in the presentation. I did mention the use of systemic corticosteroids in asthma attacks. So yes, essentially any acute asthma attack, be it moderate to life-threatening, you should always use oral prednisolone, generally for about 3 days after the onset of the attack. And it's really important to get that in early on in the presentation of symptoms as well. Option E, IV hydrocortisone, there's no benefit to giving systemic corticosteroids IV versus oral. They have the same effect. The only reason why you would give IV is if the patient was unable to take it orally, say they were unconscious or they were vomiting profusely, and you thought that they might not absorb all of the steroids. Option A is incorrect, because obviously you're supposed to be giving prednisolone as well. C and D I'll go on to talk in a bit more detail about a bit later on. There'll be some slides where we talk about the management of asthma exacerbations. They are both things that are used in asthma exacerbations, but generally they're something that you would use further on down your options. So they wouldn't be used in the first instance here. All right. So, the slide's up now. So this is basically, again, there's a lot going on here. It's meant to be kind of a helpful revision prompt for you guys to look back on. Essentially, it breaks down moderate, severe and life-threatening asthma and how you would initially treat it, and then additional treatment that you can add on. So all of them pretty much start off with salbutamol and prednisolone. If it's moderate, you could just give that via a spacer, or you could give it nebulized if you think that's appropriate. For severe life-threatening, I generally always give it as a nebulizer. And severe and life-threatening, obviously oxygen as well. And with moderate, generally you kind of, after giving the initial treatment, monitor the response. If it's a good response, then continue as needed. You often get children coming into A&E with wheezes, and you'll hear about the term stretching nebs. So essentially these children will come in, they either with asthma or a viral induced wheeze, and essentially you will monitor them, you'll give them nebulized salbutamol, and you'll see how far you can stretch it in between giving those nebulizers before sending them home. I think you're supposed to leave it until they can go 8 hours without becoming more unwell. And obviously if they start to deteriorate, then they might go into the more severe and life-threatening areas of management. Again, it's a similar thing with severe and life-threatening. You monitor the response. You just need to make sure you're reassessing more regularly, and you can step up as needed. If salbutamol alone isn't helping, then you can add back-to-back ipratropium nebulizers. And then a little bit down the bottom in purple is the more sort of further down the line things that you can try, more specialist things. As a sort of foundation doctor, you wouldn't be starting these generally by yourself. Things like magnesium sulfate, which would be the first line IV treatment that you try. You can also, beyond that, try aminophylline or even IV salbutamol. And yes, this is generally the management of acute asthma ages over 2. Children under 2, it's a bit more nuanced, and you would definitely be getting a consultant involved, and you'd be starting to think about getting a PICU bed ready for the child, particularly in the severe to life-threatening sort of areas of the presentation. Okay, so moving on now to chronic asthma. So starting with a question, an 11-year-old girl presents to GP with a 6-month history of a wheeze and nocturnal cough. You send her for spirometry and a BDR, which confirms a diagnosis of asthma. Which of the following is the most appropriate first-line treatment for the patient? Is it A, a SABA such as salbutamol? Is it B, a SABA and an ICS? Is it C, montelukast? Is it D, ICS and a LABA, which in combination is known as MART? Or is it E, don't commence any treatment, give a peak flow meter and monitor over the next few months? So I'll give you a few minutes to enter your answers into the poll. Okay, so kind of split between A and B, with slightly more people going for option A, SABA alone. Okay, let's have a little look at the answer. The answer is B, SABA and an ICS. This is important to remember because there's been a change in the guidelines recently. It did used to be that the first line would just be a SABA alone. but they've recently decided, particularly in children, that really anybody with a diagnosis of asthma should be on both the reliever, which is the salbutamol, as well as the preventer, which is the ICS, because basically it reduces the incidence of people presenting with acute asthma exacerbations. But we'll go into that in a lot more detail in later slides. I've got some more diagrams to show you. But yeah, so essentially we've talked about A and B. C, montelukast, is something that is used in the treatment of asthma, but it would be a bit further down your stepwise management. An ICS and a LABA, again, like montelukast, are both used in combination, but they're a bit later on. And E, don't commence any treatment, give a peak flow meter and monitor, is obviously not particularly useful. You've already diagnosed asthma. You don't need to give, diagnose it further by giving a peak flow meter. You want to start treating this patient. Okay. So moving to question 7. The same 11-year-old girl returns 4 months later with poor asthma control. She's been using her salbutamol at least, 10 times a week and is regularly woken at night with coughing. What would be the next most appropriate step in her management? Is it A, increase the dose of her ICS, B, commence MART, so you'd stop the ICS and then start an inhaler that's combined ICS and a LABA, C, commence montelukast, D, check inhaler technique, or E, commenced nebulized magnesium sulfate? So I'll give you a few moments to think about your answer. Okay, so overwhelmingly, generally most people have gone for D, but we've got a little answer for each one. Okay, let's bring up the answer. It's D. So most of you correct, check inhaler technique. Bit of a sort of trick question, really. Essentially, anytime a patient with asthma comes in with poor control, the first thing that you should do before changing anything to do with their treatment is make sure that their inhaler technique is correct. And sort of hand in hand with that goes make sure that they're actually complying to their treatment as well. Particularly in children, inhaler technique can be not great. Often to get around that, you'd use a device called a spacer. It's basically like a little chamber that they put their inhaler into, and it helps them catch all of the output of the inhaler and improves delivery of the medication. In children under the age of 5, you can also use a face mask as well instead of a spacer, because they struggle to use spacers as well. So with children, when you're prescribing inhalers, you should always make sure you prescribe a spacer as well. And you'll look really good on your OSCE if you mention a spacer and a face mask in children, if you get a kind of asthma station. Increase ICS dose is something that you can do, but again, you wouldn't do that before checking inhaler technique. Same as commencing a MART, it's something you could do next, but you would check her inhaler technique first. Same with montelukast. Commence nebulized magnesium sulfate is a bit of a drastic one. You could do that in the management of acute asthma. Magnesium sulfate can be given in severe cases. It could be given IV or nebulized, but there would not be any indication to do that in this child. She's not acutely presenting with an exacerbation of asthma that's not responding to other treatment. Okay, and moving straight into question 8. After assessing this girl's inhaler technique, you decide to commence a MART for this patient. On review 4 weeks later, the patient is found to have a complete asthma control. which of the following is classed as an element of complete asthma control? Is it A, only, sorry, that should be, these have all moved down. Is it A, only needing rescue therapy up to 4 times a week? B, no trips to the GP for the past 2 months? C, recent change in medication? D, no nocturnal symptoms? Or E, only mild limitation on activities, including exercise? I'll give you a few moments to answer that. So the top one, only needing rescue therapy, would be A. Sorry, that's confusingly displayed for you there. Okay, so there's a bit of a split between really the top answer and the bottom 2 answers. So I'll go on to reveal the answer. So the answer is no nocturnal symptoms. So I'll go through on a later slide all of the elements of complete asthma control. But essentially, at the top answer, only needing rescue therapy up to 4 times a week, is essentially not an element of complete asthma control. Complete asthma control is defined as essentially you're not having any symptoms at all. So you wouldn't need to use your rescue therapy at all in complete asthma control. There are some questions that can be used to assess with asthmatic patients whether they need to step up their medication, and that includes asking how many times they're using their therapy. If they're using it, I think it's more than 3 times a week, then you might want to consider stepping up their management. I think the other 2 questions are, do you get any daytime symptoms and do you get any nighttime symptoms? But don't confuse those questions with elements of complete asthma control. The next answer, no trips to GP in the past 2 months, that's not really anything to do, you know, they might have gone to a GP for other reasons. The amount of times that you go to see a GP about asthma isn't involved in the definition of complete asthma control. Recent changes in medication, again, isn't involved in the definition. As long as your medication is working for you, it doesn't matter how recently you've changed it. And only mild limitation on activities, including exercise, that's a bit of a trick question. The reason why that's wrong is because in complete asthma control, you'd have no limitations on your activities. So the answer is C, absence of any nocturnal, or sorry, D, absence of any nocturnal symptoms. Okay, so this slide, again, very wordy, just made it to help you guys with your revision. So you've got a kind of quick access guide to the main types of drugs that are used in asthma and a few examples of brand names. Often patients and nurses will use brand names instead of drug classes, so it's handy to kind of get a few of them in your head. The mechanism of actions and the key side effects as well. I won't bore you by reading out all of the information on this slide. I'll just go through a bit of them. So obviously you've got SBAs, short-acting beta-2 agonists, such as salbutamol. They work by achieving bronchodilation, by working on the beta-2 adrenoreceptors. Obviously we talked about that at the beginning of the presentation. And key side effects to think about with salbutamol is things like tremor, tachycardia, palpitations, and arrhythmias. Another important one that I learned that I haven't written on here is one that's helpful to know for A&E. Salbutamol can actually increase your lactate. So if you're doing ABG on an adult patient and you've given them salbutamol and they have a raised lactate, that could be a differential for why the lactate is raised. Obviously, you want to rule out any other causes as well. And then you've got your ICSs, so beclomethasone. The common inhaler name for that is clonal modulate. Then you've key side effects to mention to patients with that is potential for oral thrush. Something you can tell your patients is make sure that you use the inhalers after you've brushed your teeth. Just before you brush your teeth, and that can help alleviate the potential for oral thrush. Then you've got your LABAs like salmeterol. They have a similar side effect profile to SBAs. You've got your MART, which stands for maintenance and reliever therapy, with maintenance being the ICS and reliever being the LABA. So they can be used as a sort of combined inhaler. The most commonly, which I've heard of, is Symbicort, but you can get Seretide as well. And then montelukast as well, the leukotriene receptor antagonist. That downregulates inflammatory leukotrienes. We talked about that again a bit at the beginning when we were talking about the pathophysiology of asthma. And key side effects of them are things like GI upset, so diarrhea and stomach pain. Okay, so moving on to a stepwise asthma management. So this is mainly looking at management of asthma in children over the age of 5. It does in steps 1 and 2 mention what you would do for children under the age of 5. I think really beyond step 3, children under the age of 5, you'd be looking at referring to specialist care a bit earlier, because they can be a tricky age group to deal with. Sorry. So looking at step 1, and also you'll see as well, underlying all steps is the salbutamol or the SBA. So any step that you have your patient on, they'll all automatically get salbutamol. But in addition to that, step 1 would be an ICS, or in children under the age of 5, you can use montelukast. ICS comes in a very low dose, or a medium dose. I've put what those doses correspond to in that box on the side. They're all given as 2 puffs twice a day, in the morning and at night. Moving on to step 2, if that's not achieving control, you could consider adding in a LABA, so sort of taking out the ICS and adding in the MART inhaler instead. In children under the age of 5, again, you would think about just using montelukast. Long-acting beta agonists are not licensed in children under the age of 5. So montelukast would be something that you bring in a bit earlier for children that were under the age of 5. Moving up to step 3, you've got a few options. You can either increase the ICS dose in your MART inhaler, or you can think about adding montelukast. Or in older children, if you've decided to already use montelukast before using MART, you can add MART in instead. If after adding in the LABA you feel like it's not working, then consider stopping it and just using a combination of ICS with montelukast and salbutamol. So that, I think, is what I found trickiest to get my head around, is that there's a bit of there's no one definite correct answer for the next step, but generally the order to have it in your head is ICS plus salbutamol. Next step is adding in montelukast or a MART. Next step is adding in the thing that you haven't already added in, and then the next step is referring to specialist care. With the caveat that in children under the age of 5, you're not going to start a MART, because we shouldn't really start a long-acting beta agonist. And remembering at every stage that you should assess the response and always be looking to step down the treatment wherever possible. Okay, so moving on, so just a slide to kind of go over all the elements of complete asthma control. So as I said, complete asthma control should be what you're aiming for with all of your patients, and it is essentially the absence of any symptoms. So you don't get any symptoms in the day, you don't get any nighttime symptoms like waking up due to coughing, you don't need your rescue medication, so you're never using your salbutamol, you've not had any asthma attacks, you've not had any limitation on your activity, normal lung function, and minimal side effects from the medication. So moving on to the final question. So going back to the girl from the previous questions who you started on treatment, she returns for a review of her asthma in 6 months later in December. Her asthma has been completely controlled in this time. Which of the following should be offered to this patient? Is it A, an influenza vaccine, B, a rescue pack including antibiotics and oral steroids, C, the pneumococcal vaccine, D, switch to the MART inhaler that you started her on to separate ICS and LABA inhalers, or E, no additional management is needed, stop all asthma medication and reassess in 4 weeks' time. So I'll give you a few moments to put your answers into the poll. Okay, so the vast majority of you went for option A, the influenza vaccine, with a few of you going for some of the other ones. Next most common answer was E. So let's look at the results. So the answer was, as most of you guessed, A. So the influenza vaccine should generally be offered to children with asthma. It's worth noting that it can be given in two forms, either the nasal spray or the IM injection. The nasal spray is a live attenuated form of the vaccine, and unfortunately for children who might be a bit immunocompromised because they've got very severe asthma and they're on long-term systemic corticosteroids, so they're taking regular prednisolone, you should avoid giving the nasal form of the vaccine to those children. So yes, the correct answer was the influenza vaccine, but just keep that bit of information at the back of your head. B, rescue pack including antibiotics and oral steroids. That's not really part of asthma management. That's more for COPD patients that get infective exacerbations. Often they will be given a prescription for what's called a rescue pack, so that when they start to get their symptoms, they can get their treatment without having to wait for a GP appointment. C, the pneumococcal vaccine, that can be offered to patients who have severe asthma, who are on systemic corticosteroids and so are a bit immunocompromised, but that's not the case for this patient. She's not on systemic corticosteroids, so you wouldn't offer that. D, switch MART to separate ICS and LABA inhalers. Not sure what the benefit of doing that would be. Only if I suppose you were thinking about stopping the LABA, but then you just switch the MART to a standalone ICS. Or E, no additional management is needed, stop all asthma medication and reassess in 4 weeks' time. Obviously, the question says that she's completely controlled with regards to her asthma, so you might want to think about maybe stepping down her management, but stopping it altogether and reassessing in 4 weeks' time is not the way to go about it. You want to step, just like you step up in a stepwise fashion, you step down in a stepwise fashion. So the next step would be to switch the MART to an ICS alone. and then see how she gets on with that. All right. So, and then just a final slide. Again, sorry, I know this is very wordy, but it's just to kind of give you a few pointers for when you're revising. A lot of it is information that I've just gone over about the influenza vaccine and the pneumococcal vaccine. It's just to remember that obviously asthma is a chronic condition, so you should be monitoring these children in GP every 12 months at least. And in that review, you're going to be looking at how well they're adhering to their medication and how well they are taking their inhalers. Children, it's very common, children with chronic conditions can be really difficult to manage. Trying to get a child to take an inhaler regularly can be really difficult, and a lot of parents struggle with having to make their children adhere to the medication regimes. So it's always good to sort of check in and see how the patients and the parents are managing as well. A big part of paediatrics is not just looking after the children, but looking after the parents as well. And then assessing whether or not, how well controlled their treatment, their asthma is on the current treatment. Do you need to step up? Do you need to step down? And another important thing is an asthma action plan, which is should be given to all children with asthma. It tells them what their treatment is, what to do if their symptoms are getting worse, and what to do if they're having an acute asthma attack. That's another important one. If you get an asthma canestation and an OSCE, mentioning an asthma action plan will definitely get you some extra points. Okay, so that is the end of